Most people with spinal stenosis wait too long to consider surgery, and a small number waits too little. That decision, when or if you actually need an operation, is the hardest conversation in spine care. If you've already been told you have spinal stenosis and you've done physical therapy, taken medications, maybe had an injection or two, and you're still measuring your day in how far you can walk before the leg pain stops you, this video is for you. I'm going to walk you through exactly how a spine surgeon decides who needs surgery for spinal stenosis, what makes it more urgent versus elective, and the 4 questions I ask every patient before I bring up an operation. I am a spine surgeon at Twin City Spine Center. I've sat across from hundreds of patients having this exact conversation. The ones still on the fence, the ones who waited 5 years too long, and the ones who came in expecting to need surgery and walked out with a different plan. The decision isn't about how your MRI looks, it's about how your life looks. By the end of this video, I'm also going to tell you the one situation where you should not wait, where stenosis becomes an emergency, not a decision. Most patients don't know what those signs are, and they should. Stay with me for that. Here's the framework. Surgery for spinal stenosis falls into two very different categories. The first one is urgent, meaning the nerve compression is causing damage that won't recover if we wait. That's rare. The second is elective, meaning your symptoms are bad enough that surgery offers a real quality of life improvement, but the timing is yours. That's the vast majority of cases. So this isn't a should I have surgery question, it's a when am I ready question. Let me start with the small group, the urgent cases. These are the situations where I tell patients, don't wait, don't get a second opinion next month, get evaluated this week. The first is a syndrome called Cauda equina. The Cauda equina is the bundle of nerves at the bottom of your spinal cord that controls your legs, your bladder, your bowel, and your saddle area, the parts of your body that touch the saddle when you sit on a horse. When stenosis compresses this bundle severely, you can develop numbness in that saddle region, loss of bladder and bowel control, or rapidly worsening weakness in both legs. That is a surgical emergency. If you're experiencing those symptoms, you should go to an emergency room, not wait for a clinic appointment. The second urgent situation is progressive weakness, not the heavy, tired feeling stenosis usually causes, actual weakness. Your foot starts dropping when you walk. You can't push off the ground with your toes. You notice you cannot lift your knee like you used to. If that weakness is getting worse week over week, that's a nerve under enough pressure that waiting can mean it doesn't fully recover. These two situations, Cauda equina and progressive weakness, are why I tell patients with stenosis to know the signs. Most people will never have them, but the people who do often delay because they don't realize what they're actually seeing. Okay, that's the urgent group. Now let's talk about the elective category, where most of this conversation actually lives. Because for everyone else, the decision comes down to 4 questions I ask every patient. Question 1, how is this affecting your life? Not your MRI, not your imaging, your life. The most important thing I want to understand is, what stenosis is taking from you? Is it your morning walk with your spouse? Is it your ability to stand up long enough to cook dinner? Is it sleep because the leg pain wakes you up? Is it the round of golf you used to play every week? The reason this question matters more than imaging is that we operate on people, not MRIs. I have patients with severe looking stenosis on MRI who walk 3 miles a day with only mild discomfort. I also have patients with moderate stenosis on MRI who cannot walk to the mailbox. We don't operate on MRIs again. We operate on what your spine is doing to your life. Here is a common misconception about stenosis surgery. People think the MRI decides, but it doesn't. The MRI just tells me what's there. It doesn't tell me whether it is time to operate. Your life tells me that. Question number 2 is, what have you actually tried? The standard before considering surgery for stenosis is what we call a reasonable trial of conservative care. That generally means physical therapy focused on flexion-based exercises, postural and core work, sometimes activity modification, often medications, and in some cases, epidural steroid injections. The minimum is about 6 to 12 weeks of consistent guided effort, not a single appointment with a physical therapist or one round of ibuprofen. The one exception is if your symptoms are excruciating or if there is a neurologic problem like the weakness we talked about earlier. Those situations don't wait 12 weeks. If you haven't truly tried those things and try them under guidance, surgery isn't the next step. I send patients back to start or to start properly all the time. Question 3, do your symptoms match your imaging? This one is more technical, but it matters. When I look at your MRI, I am not just looking for narrowing. I'm asking whether the narrowing I see explains the symptoms you're describing. If your stenosis at L4-5 and your leg pain is coming down the front of your thigh in a pattern that matches an L4 nerve root, that may be a match if the narrowing is in the foramen, but it may not be a match if the narrowing is in the subarticular recess, because those are two different areas that will compress different nerves. If your imaging shows stenosis, but your pain doesn't follow that nerve distribution, if the symptoms and the pictures don't tell the same story, surgery is unlikely to give you what you are hoping for. This is one of the most common reasons stenosis surgery underdelivers. The operation is technically correct. The surgeon can do the greatest operation, but the decision to do it wasn't. Question 4, are you medically and emotionally ready? This is one I think gets undersold. Surgery is a controlled trauma to your body. Recovery takes a few weeks. Healing is influenced by your overall health, your activity level going in, your sleep, your nutrition, whether you smoke, and your support at home. And emotionally, you need to understand what surgery can and cannot do. The best operations for stenosis are excellent at relieving leg pain and improving walking tolerance, but they're less predictable for back pain. They don't reverse decades of deconditioning. They also don't undo other things going on in your spine that are not part of the operation. A patient who walks in with clear expectations, who's done the work to optimize what they can, that's a patient who tends to do extremely well. Now, there's one more thing I tell every patient at this stage of the conversation. It might be the most important thing in this whole video. Most people don't know it, and it changes how they think about timing. Stenosis surgery is not a last resort. It's not something you do when nothing else has worked and you have no other options. That mindset, I'll wait until I absolutely have to, costs people years of their life they'll never get back. Here's the truth. If your symptoms are significant enough that you're considering surgery and your imaging supports a diagnosis and you've given conservative care a fair shot, waiting longer doesn't usually make the surgery easier or the recovery faster. In some cases, it makes it harder. Nerves that have been compressed for years don't always bounce back as completely as nerves that have been compressed for months. I'm not telling you to rush the surgery. I'm telling you to stop thinking of surgery as a failure. For the right patient is the moment they get their life back. The decision isn't, have I suffered enough yet? The decision is this the next right step for me? And usually I tell patients this is going to be based on your quality of life, your day-to-day level of activity. If you are at this stage of the conversation, you've done the conservative work, your symptoms are meaningful, and your imaging tells the same story your body's telling, what comes next is a real evaluation with a spine surgeon, not to schedule an operation, to actually understand whether you're a candidate, what kind of operation makes sense for you, and what the realistic outcomes looks like for you. That's what I do at Twin City Spine Center. If you're in the area or willing to travel, the link to the practice is in the description. For everyone else, wherever you live, find a surgeon who explained the decision the way I just did. Someone who asks about your life before they ask about your MRI. Someone who tells you when not to operate. That's the surgeon you want sitting across from you. The next video in this series walks through exactly what decompression surgery for stenosis actually involves, what the operation is, how recovery works, and what most patients don't expect. If you missed video 2 on conservative treatment, that's also linked below. I'm Dr. Omar Ramos. I'll see you in the next one.